and thank you very much. And what I'll do, if you've got questions for Chris, pop them in the sidebar and we will go through the questions at the end. Thanks very much. Sharing the screen.
Thanks, Linda, and tēnā koutou katoa. My name's Chris Mules and I'm based in Auckland, but I'm working with the Department of Prime Minister and Cabinet, and within that the transition unit for the health and disability reforms. Thank you very much for your invitation, and what I'm talking with you about is a complex topic and I've got 10 minutes, so I apologise in advance. I'll talk at quite a high level, but can take questions and comments at the end. Been very interesting just to sit here quietly and listen to what's going on. The messages I've taken from that are you're really interested in what the future holds. Everybody's battling in the COVID environment, and I live in Auckland, so I understand entirely what you're going through. I'm working from home at the moment. So you're interested really in how communities get engaged in both the reform process and in the future operating model. You're probably also interested in how the consumer voice is going to be picked up in the future. You've got probably a little bit of uncertainty around what's going to happen with your funding from the DHB. And also, of course, you'll be wondering where Waitakere HealthLink specifically sits in the future. So I'm not going to address many of those things in my presentation, but I'm happy to take questions or comments at the end. Could I have the next slide, please, Tracy? Whoops, just skipped over. Yeah, thank you. So I'll talk very briefly about the future system operating model. So there's some great jargon there. It's really about the overall structure of the system, what the implementation timeline is, some of the big shifts that are intended to occur through the health reforms, where the New Zealand Health Plan fits in, and then I'll finish with talking about some aspects of primary and community care, which is most relevant for you, and how the locality approach is intended to work in the future. Next slide, please. So, very high levels future system operating model. So, starting at the top left-hand corner, hospital and specialist services will be managed nationwide through a new organisation called Health New Zealand. Health New Zealand will have two major roles. One is it's going to be the planner and commissioner of health services nationwide. And secondly, the hospital services will all be delivered through Health New Zealand, which will be the single nationwide employer of all staff currently employed by DHBs. So essentially the functions of the 20 existing DHBs will merge into Health New Zealand. So you can think of this as there being one DHB instead of 20 as there are now. At the same time, there'll be a national public health service also within Health New Zealand that will bring together the existing 12 public health units into a single nationwide unit. On the right-hand side, primary and community care will operate with a strong locality focus, so will be much more oriented to local communities. There'll be an iwi Māori partnership board at the local level that will be a partnership between local iwi and Health New Zealand. The partnership boards will be will also have a very strong line to the Maori Health Authority, which will exist in partnership with Health New Zealand. Maori Health Authority will lead efforts to achieve equity in access and outcome for Maori, and will have some direct roles, which I'll talk to in a moment, and some through its relationship with the Ministry of Health, with Health New Zealand, and with the iwi Māori partnership boards. So in summary then, 20 DHBs will be merged into one Health New Zealand, and a new Maori Health Authority will be developed at a nationwide level. Next slide, please. So implementation timeline. If you look to September, which is where we are now, you'll see that fortunately we're on track, given that the Minister announced the interim Maori Health Authority and Health New Zealand board membership in the last few days, or in fact it was on Thursday last week. So they will function as ministerial committees in the interim until the legislation is passed that will allow them to take over their formal responsibilities and accountabilities. The legislation is due to be introduced this month. It's likely to be a little bit later than that, so we'll be into October. Through October, November, December, they will be going through an orientation process, inducted into their new roles, and gradually will take over some of the responsibilities in an informal sense. In other words, they remain as ministerial advisory committees until the legislation is passed. They'll be active in the budget bid process, which is underway now. This is the budget for the 22-23 year. Staff will begin to transfer into Health New Zealand and into the Maori Health Authority from about January next year. And that transition process will be complete by July 1, when the two organisations, Health New Zealand and the Maori Health Authority, come into formal status once the legislation is passed. It's at that time that the transition unit that I currently work for, that will be disestablished, because, as the name suggests, the transition unit is supporting the transition process to those new entities existing, and is also getting some of the work underway, which will underpin the new health system. An example of that's down in the bottom right-hand corner, the interim New Zealand Health Plan. Could I have the next slide, please? Okay, if we could just go back one slide, thank you. So, as you may or may not be aware, the changes that the government is making to the health system are a result of about 2 years of work, initially by the Health and Disability System Review Committee, led by Heather Simpson, which initially did a case for change and then delivered recommendations for the new system, and then Cabinet made decisions about the structure that the new system will have. Underpinning the reforms are 5 what we've labelled as big shifts that will underpin the reforms, which will bring changes in focus and changes in models of care, in other words, how services are delivered, and an increased focus on equitable outcomes. So very briefly, the new health system will reinforce treaty principles and obligations. Secondly, there's going to be great impetus put behind boosting primary and community services available in local communities, and that's where the locality approach comes in. Thirdly, there's going to be greater consistency of access to hospital and specialist services across the country. You may have heard the phrase postcode lottery, which really is a description of an environment that was created in an unintentional way by having 20 DHBs. There's very considerable variation across the DHBs, and the health reforms are aimed at having greater nationwide consistency. Fourthly, the health sector is slow to make the kind of changes to adoption of digital technology that other industries have done, and there'll be increased emphasis put on that, both to help flow of information within the health sector, but also to give people better access to their own information and information about services. And lastly, there's going to be increased emphasis put on health services on the health workforce. As you'd be aware, there are considerable and growing health workforce shortages, which are partly the result of New Zealand not producing sufficient workforce of its own, and secondly, of course, by the border freeze that has occurred, which has stopped the flow of an international workforce into New Zealand. So those are the 5 areas of focus of the health reforms. If I could have the next slide, please.
Sorry, I think we've got a sticky key and it takes a while to do. Oh, here we go.
Thanks. One important aspect of the health reform environment is a commitment to longer term planning at a nationwide level. So this is part of having greater sense of future direction of the New Zealand health system, and that being planned nationwide and with a long term, that's a 5 to 20 year focus. Now, it may surprise you that that doesn't happen now, but it is seen as a major impediment to dealing with the kind of challenges that the health system faces. So the first full New Zealand health plan will be developed by Health New Zealand, the Maori Health Authority, by 2024. But in the meantime, there'll be an interim New Zealand health plan developed for July next year, July 2022. And that's one of the areas that I'm working on at the moment. Next slide, please. Just very briefly, to give you a sense of what the respective roles of Health New Zealand and the Maori Health Authority are. So Health New Zealand is the lead planner, organiser, funder of the future health system, and as I mentioned, it will also be a major employer. It's going to have about 85 to 90,000 staff across New Zealand, which will make it New Zealand's biggest organisation. But from a commissioning perspective, Health New Zealand will be the lead commissioner in the system, but it will work in very strong partnership with the Maori Health Authority in services that impact upon Maori access and outcomes. The Maori Health Authority will be in that partnership role with Health New Zealand. It will also work with the Ministry on policy matters and will commission kaupapa Maori services and other health services that target Maori. So the partnership relationship between Health New Zealand and the Maori Health Authority is going to be absolutely pivotal for the success of the future health system. Next slide, please, whoever's controlling it, thank you. I warned you this was going to be a whistle-stop trip through something quite complex. So I'm turning my attention now to primary and community and population health and the locality focus. So as I'm sure an organisation like yours is very well aware, health outcomes are determined by two major things. One is health services, which it's thought that are responsible for about 40% of health outcomes, with the other 60% being a complex array of socioeconomics and personal lifestyle choices. So there's a really strong commitment to working to the health sector, working more effectively with housing, with justice, with education, with welfare, both at a nationwide level and at a locality level, such as West Auckland, and through working more effectively to reflect the needs and priorities of local communities. This is really strongly linked to the increased emphasis that's going to be given, increased emphasis and investment that's going to go into primary and community health services, and not a reduction in funding to hospitals, of course, but a rebalancing of the system. Over the last 20 years, there's been, in the DHB model, there's been a slow but progressive shift to increasing investment in hospitals and decreasing the relative investment in primary and community services. So the aim is to rebalance that and to have much stronger connection with the other government agencies that have a huge impact on health outcomes. So next slide, please. So what in effect this means is there's going to be better connection between primary and community services through provider networks, and those services will broaden the base of what goes on inside primary healthcare, strengthen the relationships with the NGO and not-for-profit sector, have a strong orientation to Kaupapa services I mentioned, to Pacific Health Services, and to rural health services. And within that, focus on some priority cohorts. And so you may find that a little bit of a struggle to read. So the right-hand side of that graphic describes what the priority cohorts are, and I'll just summarize those for you. But they are families and babies. They are public health, so protection, promotion, and prevention. Healthy young people, mental health and well-being, chronic illness and complex conditions, and aged care and the frail elderly. So there'll be broader-based provider networks in primary and community services, and an increased focus on those priority cohorts. But as well as that, stronger connections between primary and hospital services, stronger connections with social services and with public health. How's this going to be achieved? There's going to be better sharing of data. There's going to be better access for people through use of electronic digital channels. There's going to be shared pathways and shared care plans, shared clinical governance, and increased emphasis on measuring impact and outcomes. So we're just about at the end here. If we could move on to the next slide, please. So just finishing up with what do we mean by a locality approach? So what this is about is working more strongly with local communities and mana whenua around how primary and community care can be best delivered. So it's through engagement with local communities, through organisations such as yours, It's about establishing provider networks, so better connections between primary care and community services and NGOs. And thirdly, partnering with community and social service providers to focus on some of these complex issues such as family violence, drug and alcohol misuse, mental health and well-being, for example. So Health New Zealand will be responsible for implementing this. It's going to take a long time to get these locality approaches in place. So it's going to start through prototype or early adopter models, and that will start this financial year, the year we're in now. And there'll be a phased approach to rollout of that. We could have the next slide, please. So that's it. Whistle stop trip, and I'm very happy to answer any questions or comments you may have.
Thank you very much, Chris. It's really helpful. There was one question, is whether you would be willing to share that slide pack or not? If it
Yes,
would be...
yes.
All right. Okay, so if we just let us know if anybody wants us to send that PowerPoint, because it's a lot to digest, and we really appreciate someone who's actually doing the work coming to speak to us. Now, I do have a few questions here, my chat bar. So the first question is from, now I've got a different kind of model here, and it's go out of participants, right?
I'm very pleased you're operating this.
Oh, yes, I know. Well, this is, yeah, usually I've got council staff doing this. So here we go. So the first question from Paula Mitchell from West Auckland, Stroke West Auckland. Are DHB hospitals going to be set up for special things? And I think what Paula might mean is different hospitals with different specialties.
The simple answer is yes. There's going to be a planning process leading to the first full New Zealand Health Plan in 2024. That planning process will aim to describe the current range of services from every hospital in New Zealand and what the intended future role is of those services. Now, that's really, it's a very complex undertaking. The first time it's been done in New Zealand, and the role of hospitals will continue to evolve over time. But if we just think about Metropolitan Auckland, which has got 3 DHBs in it, those DHBs up until relatively recently, and I used to work in one of them in Counties Manukau for 10 years, they have acted reasonably independently, but over the last 18 to 24 months, there's been much stronger work across those three DHBs around thinking about the current configuration of services and their view of what the future role is, to encourage a core set of local services in the local hospitals, but potentially reducing the duplication of services that occurs across all hospitals. So that process is still underway and will be picked up and built upon as part of Health New Zealand's role.
Thank you. So the next question is from Judy Blakey. What will you do to address the digital divide, which is underappreciated, especially amongst older people who are often housebound?
Yeah, it's a very important issue. And there's no simple answer to it. There are two issues that underpin this, of course. One is the availability of the hardware and software and data that and devices that are required to access digitally based information. And secondly, there are significant parts of the country where broadband is simply not available in rural communities. And those two issues need to be addressed, but certainly in respect of people who don't feel that they are digitally literate, there will need to be other options available to them.
Thank you, Chris. The next question from Gayleen Maurice, and not surprising, all the work she does in the mental health sector. What input have you had from the mental health sector?
We are just establishing, so we here, I mean the transition unit, and we are looking after the transition. We will be replaced by Health New Zealand and by the Maori Health Authority at a national level. The Ministry of Health, as you'll be aware, is driving a nationwide work program around mental health and addictions, strengthening those services. A lot of that role and responsibility will transfer into Health New Zealand and the Maori Health Authority over time. But we are in fact just setting up a number of expert advisory committees to work with to initiate work so that can then be handed over to the Maori Health Authority and Health New Zealand. And one of those groups is focused on mental health and addictions. So we're just beginning that work. We have been familiarising ourselves with the work that the Ministry is leading and the strengths and opportunities and potential weaknesses of how the Ministry is going about that work. You'd be aware there's been a great deal of noise about the slow progress with that work. Yeah, so we're just beginning that work on behalf of Health New Zealand and the Maori Health Authority, and over time a lot of that work will transfer into the new organisations.
Thank you. I don't know if we've got time for a follow-up question from Gayleen, but she just said Waitakere shared vision works in a co-production design, not just a co-design way. We are encouraged to be are we going to be financially encouraged to work with the new system, or do you feel the new system isn't ready for us? Is this too scary a model?
No, it's not a scary model at all. In fact, you are very well established as part of the furniture of the health system and your local community. If anything, your role will be encouraged to increase. There's going to be greater emphasis given to, as I said at the outset, community engagement and the consumer voice. You're active in both of those spaces. So I would not have any concern, if I were you, that your role is going to diminish. At a transactional kind of level, I'm sure that your funding from Waitemata DHB will be rolled over into the future environment, as will all contracts, until such time as the new organisations are able to work with you in a longer term relationship. So I wouldn't have any concerns on that front at all.
Thank you, Chris. I'm sure a lot of the organisations here are feeling quite reassured by that, at least another year reprieve at least. So do you see, this is from NeuroConnection, Thomas Hoey, do you see in the long term that the health sector will move towards a self-managed system where patients are funded by the health organisations and choose what services they require to fit their particular ailment or condition, similar to self-managed super, for example? A bit of a segue from the other question, I think.
It's possible. It's possible. There have been some piloting of that kind of approach in the disability sector, and in other words, budget holding by patients or consumers or clients. It's possible that that model may be tried inside the health system. But it's not on the immediate reform agenda of the government.
Thank you. From Belgic Core of Waitakere Ethnic Board. Hi Chris, how can this roll out in a timely manner when the country does not have enough health professionals by next year to run it? Where is the support on the ever-increasing ethnic communities and their needs?
Yeah, as I mentioned during my presentation, the availability of the health workforce is a major challenge, particularly in the COVID environment. You may have heard the Minister addressing these issues in recent times, being challenged about, given the COVID environment, is this actually the right time to be restructuring the health system? His response was, there's never been a more appropriate time, because the reform environment is going to make better use of the available health professionals, and its commitment to long-term planning will support the future availability of the required health workforce. There are some significant issues right now to do with the freeze on the borders, which makes importing a workforce very challenging. And as you may be aware, New Zealand's got a greater reliance on the internationally trained workforce than any other OECD country. So that issue about border opening is particularly challenging at the moment.
Thank you. And from Janice Regan, one of our valuable consumer reps. Thanks, Chris, for the overview. Great to see that healthcare staff are going to be valued and an increased focus on training. There is a huge evidence base that looking after staff health and wellbeing is an antecedent to achieving all that you talk about. How is this going to be focused on?
I can't speak to that in detail. You're asking a kind of how question that the responsibility for the health workforce sits inside the Ministry of Health at the moment. On delivery of the funding to support training and development, that will transfer into Health New Zealand and into the Maori Health Authority, and is likely to be a very early area of transfer. They will be responsible for the how question. But I'm expecting to see a mix of interventions around increasing the number of funded education posts, increasing availability of training, diversifying the workforce, so having new workforce roles. These are not new trends, but I'm expecting an acceleration of a number of the trends that have been underway for a few years now. And of course, increasing the role of the Maori and Pacific workforce in particular.
Thank you. There's a few more questions, but I'm going to not take any more questions after what we've got at the moment. We've got quite a lot, and are people happy for us to go on? Because I think we had just scheduled an hour, but everybody's okay. Good, DJ, because you've got a question. Okay. So the next question is from Stella from West Auckland Hospice, or Hospice West Auckland. How will these changes support an integrated approach to palliative care across the community, primary care, NGOs, and hospital and specialist services?
Too soon to say, I'm afraid. I can't get into the detail of that, but about palliative and end-of-life care is a really important part of the primary and community approach that I mentioned, primary and community care, and I would expect it's going to have a very strong focus within that. I can't speak to the detail of that, unfortunately.
All right, so where are we? Tim, thanks, Chris. You mentioned perceived uncertainty around long-term funding arrangements between the DHB and organisations like Waitakere HealthLink. There are several organisations in similar situations. Would appreciate any insight you can provide, particularly on the likelihood of status quo being maintained. I think that might have been answered when you said that the current contracts will be rolled over.
Yeah, I think that's highly likely. In fact, there is work going on that now. As you might imagine, there is a staggering number of contracts nationwide that will need to be rolled over, given that Health New Zealand and Māori Health Authority take over not only 20 DHB's responsibilities, but also services that are currently funded directly by the Ministry of Health.
Thank you. So from Judy Blakey again, having 20 DHBs distilled into one in charge of commissioning primary care is concerning because DHBs have yet to demonstrate they understand primary care. How will Health New Zealand engage with primary care to rebalance the system? You've covered some of that off, I think.
Yeah, it is a very good question and is fundamental to a lot of what the reforms are about, which is about strengthening delivery of services in primary and community settings and strengthening the relationship between primary care and NGOs and other community-based services. So there's going to be a dedicated arm of Health New Zealand which will be focused on commissioning of primary and community services and will have its own budget appropriated by government. In other words, there's not going to be resource allocation decisions made in the split between hospital and primary and community services made within Health New Zealand. It's going to be made at a government appropriation level. So a lot of what has happened over the last 20 years, which is a gradual shift of resources from primary and community care to the hospitals, will not be possible in the future arrangements. So the government will be able to invest directly in increased funding for primary and community care because there'll be a separate appropriation inside Vote Health.
Thank you. So, kia ora, DJ Adams, the current chair of the Consumer Council for the DHB, and I think fellow Massey High Schooler. So, as well as scaling, will non-Māori have access to services and products that the Māori Health Authority commissions?
I would expect so, as it is at the moment. If you look at most Māori and Pacific providers, well, in fact, all Māori and Pacific providers, as far as I'm aware, their services are open to non-Māori, non-Pacific as well. And I would expect that to continue. What is different about Māori and Pacific providers is the way in which they work, their values base, their models of care, and their capacity. And that's where there'll be increased investment. These services, people will not be excluded from accessing those services who want to access them in exactly the same way as now.
All right, there's a question from Samuel. Auckland is totally different from other cities and regions with a great number of population. Any ideas that you discussed? And I also just will add in on that because it kind of talks to that community voice. How do you see communities and consumer voice being able to be heard by one national entity, in particular with all their different communities have very different needs? Yeah,
so you're absolutely right that within the health system, Metropolitan Auckland is a special case, you know, where a huge proportion of the New Zealand population. To date, we've had 3 DHBs in one city, which has led to a whole lot of complexity. And the forecasts are for significant population growth and ageing, which means significant increased demand for health services. And of course, we've got a much more culturally and ethnically diverse population in Auckland than in the rest of the country. So it makes for a very complex set of planning and delivery issues. So your question around how is a nationwide organisation going to have connections with local communities such as West Auckland, that's why I focused in this presentation on the localities, the locality approach. So I can't define precisely what a locality is at the moment, but West Auckland will be one. I think you're a kind of exemplar for a strong community of interest that has really got its act together in terms of engaging with the health system. So it's through that engagement in commissioning of primary and community services is going to be the single most important element of that. And so Health New Zealand will have staff at a locality level who will work with organisations such as yours around defining and prioritising local population needs and ensuring that those services are commissioned to meet those needs, and working with Health New Zealand to hold the providers to account. So, working with the commissioning role, both on planning and on monitoring services and on impacts. And secondly, there'll be avenues for the consumer voice to be heard at provider level. So to inform the providers both of primary and community services and of hospital services so that they can build the consumer voice into their work. So it's not going to be weakened. If anything, it's going to be strengthened, both community engagement plus the consumer voice.
Thank you. And are people happy if we keep going with questions? We've gone over time.
Can I just say something here in case anybody's missed it? There are 8 new cases in the community today.
Thank you, Kate. We always like to get that 1 o'clock update. So the next question is from Tim Edmonds at the Well Foundation, who do a great job of raising funds for our hospital and North Shore. To what extent will each hospital have their own decision-making structures and senior management, or will this exec leadership all sit at the Northern Divisional level?
Really good question. I can respond to that at a based on work that's been done so far, but of course Health New Zealand will make its own decisions about the structure that it has. But what has been decided already by government is that there's going to be a regional structure to the hospital services. So by region, of course, we mean in the northern region, which West Auckland is part of. At the moment, there are the 4 DHBs, Northland, Waitakere, Auckland and Counties Manukau. So there'll be a regional director of hospital services for the northern region. There will not be 4 chief executives reporting to that regional director or regional chief executive, not sure what the title will be. But there will be hospital managers. Any hospital needs a management structure. So there'll be a manager of Waitakere Hospital, there'll be a manager of North Shore Hospitals, but instead of reporting to a DHB chief executive, they will report to a regional management structure. And there are going to be advisory boards, which may well be subcommittees of the Health New Zealand board, who oversee the regional management structure.
Thank you. And I also, just on that note, welcome Paula Seymour, the new General Manager of Waitakere Hospital, to this call, and many other staff from our DHB. Now, the next question is from Marielle Freeberg from the New Zealand Disability Support Network. Thank you, Chris, for this presentation. Just wondering how the disability sector, disabled people and disability providers have been taken into account in this model. Does that somewhat fit in with that primary care, Chris?
Well, there are a couple of elements to that. One is people with disabilities have particular health needs. So they will be a priority group in terms of ensuring that the health services do better for people with disabilities. That's point one. Point two is in respect of disability support services, whilst the government decision has not formally been made about where disability support for people with disabilities aged under 65 will sit in the future arrangements, it's likely that they will not be within the health system structures that I have outlined, but will sit elsewhere in the government sector.
Thank you.
As you'd be aware, people with disabilities generally think they don't belong with health services because they have disabilities rather than health needs. They, of course, have their own health needs, but their support needs are not best served by the health sector.
Thank you. And I'm sure Maureen Wood is nodding her head and going, yes, we need better care for our disabled community, people with disabilities. And Judy Blake has just put up a little plug for the Auckland Have Your Say feedback on the Council's draft age-friendly action plan. So that looks like, oh, we've got one new message. Yes, so we just have one self-serving question for Waitakere HealthLink, and on behalf of our community, Chris, I hope you don't mind, this will be the last question. How can Waitakere HealthLink continue to connect NGOs in the West as the reform progresses? Can WHL be a conduit for it to make sure we keep people up to date?
Yes, I think that's a really good point. I'm not sure whether you are connected to the Transition Unit newsletter. If you're not, if you don't receive that, or if your member organisations don't receive that, just send me an email reminding me, and I'll make sure you get on the mailing list for that. So that's point one. Point two is, I'm sure as Health New Zealand develops over coming months, it's going to give priority to a presence in local areas, local districts and communities. But the Transition Unit will be having a roadshow through October and November, where we'll be talking to these kinds of issues more strongly than I have now. So when you email me about the access to the newsletter, can you also please just remind me about the roadshow, and I'll make sure that you are linked with any information about that.
Thank you, Chris. And DJ's just put up a link to the your department there, DPMC Business Units Transition Response Health and Disability System Review, but also Tracy said she'll send that out to everybody today as well. So I'm going to thank you so much, Chris. It's a lot to take in, but I think if I think we'll send everybody out your PowerPoint in a bit more time to digest. And as you can see, we've got a very engaged health community here. We've got a great community who are very interested in how this pans out, and we all will support whatever is going to make access to healthcare easier and better for our people. So thank you so much, Chris. Wonderful. So that comes to the end of our meeting, and I just want to thank everybody for being so engaged. It's such a joy to see everybody asking questions, nodding, and all your smiling faces. And thank you for all the work you do. It's absolutely wonderful. You know, you're just champions. So I'm going to ask Hinimoa, one of our executive members, to close, and then you'll be able to go and get some lunch.
Kia ora, tēnā tātou katoa, just supporting all the thanks that you've given, Linda, to every single person who's in attendance, and Chris for the information and the mahi that you do and shared. Me inoi tātou, let us pray. And this is something we would usually say when we travel, and I'm going to share it because we are kind of traveling and navigating our environment in this COVID environment at the moment. So I'm going to share it in English and in Māori. Let us pray. May peace and well-being be widespread. May the sea be like greenstone, a pathway for us all this day. Let us show respect for each other, for one another, and bind us all together. Kia hora te marino, kia whakapapapau namu te moana. Hei huarahi mā tātou i te rangi nei. Aroha atu, aroha mai, tātou i a tātou katoa, hui e, tā hiki e.
Kia ora, Hanimai, thank you. So thank you, everybody. Safe travels wherever you're going, and stay safe, and shout out for everybody to get immunised. Thank you very much.
Bye.
Thank
you.
Bye.
Bye.
Thank you all. Bye.